day yesterday was spent with a number of oncology and allied mental health groups to develop a vision and set of values and principles for any Pharmacare blueprint for Canada that may be presented to us by any stakeholders and, of course, particularly by governments. Some patient groups have already joined together to develop blueprints, and we really felt that we needed to do the same, particularly since this issue is heating up, and I'll talk about some of the recent history in a moment. So to look at the agenda for this webinar, by the way, just to mention, I would say there were approximately 15 groups in the room yesterday. I didn't count, but I think that's right. So it was very lively discussion. So the webinar agenda will be a historical background, a little bit about Pharmacare so far, some proposed models that we heard about on the panel yesterday, some information about international comparators that we also heard. We'll have a little bit of a mental health lens put on the issues. Then I'd like to, for the first time, unveil the draft vision, values, and principles that we developed yesterday, and talk a little bit about next steps we discussed. So if we could go to the historical background first. I'm not going to go way back into the 90s and 80s, even though I'm old enough that I could. I'll start with 2003, the last First Minister's Health Accord. And it was the first document really that I think framed in some detail what a national pharmaceutical strategy might look like. And the commitment at that time was that no one would be denied access to necessary, very high-cost drugs based on where they live or their ability to pay. And I'd like you to think about that as we go through, because I actually think that that is the nub of the health policy problem that we as patients hope Pharmacare would resolve. It's the gap in our health policy from our perspective. So what did they say then about how this would happen? So on the next slide, if we could have it, Matt, they proposed two options for design. One of them was a sliding scale for families to pay based on total family income, going from 0% to 9%, depending on your income. Or they said we could have a 5% fixed income amount that families would pay. So their proposal basically was that families would, that the cost for this Pharmacare program would come out of family income. And in the next slide, you'll see that and that went nowhere. And I was actually sitting outside some of the rooms where some of the provinces met to discuss this, to hear how things went. And the truth of the matter was they couldn't come up with an agreement on which of these formulae would be appropriate. So then we had the fairly well known commissions of Kirby and Romano in 2002, and both of them supported a catastrophic drug plan for Canada with and both identified a maximum of $1,500 per annum as a threshold for catastrophic drug transfers to a federal plan. So if you had more than that cost for your drugs per annum, the federal government would jump in. Kirby had a slight variation on that, but that was basically, they basically were pretty much aligned in what they were recommending. And again, unfortunately, after these two reports were tabled in the House, they really didn't, there was no follow-through in terms of implementation. I suspect for the same reason that the first one didn't, that's very hard for the provinces to come to agreement on actually how they would do this. So moving on to the next slide, you can see that more recently, the Ontario Minister of Health has become a champion, I hope he wouldn't mind me calling him that, for Pharmacare as defined by the government. And this is, I want to just make a stop here for a second and say that the reason I picked the title for this webinar of caveat emptor, be careful what you wish for, or let the buyer beware, is because I think one of the big issues that we have is that different stakeholders think that Pharmacare means something different, and there is no common definition. And so I hear groups saying, of course I'm in favor of Pharmacare, and then I say, well, which Pharmacare? And then it's not necessarily the ones that the other stakeholders are proposing. So, so I attended a roundtable that the Minister of Health held in June of 2015 to become educated about potential models for Pharmacare, as well as some of the economic issues. There were a number of academics who've written on this subject, provincial government bureaucrats, not just in Ontario, but I think there were 7 or 8 provinces represented, both through bureaucrats and politicians. There were some consultants who worked in the private field, but who had been in the public field and knew quite a bit about it in the room. There were no pharmaceutical industry people at this meeting, and I was actually the only patient representative at the meeting. So, and so you're getting my take on this, although there is a complete summary of the report if you want to read it online. Basically, what I heard in the room was that we have a number of issues. The cost of new and innovative drugs, very big issue. The price of drugs also, and those are not the same. Price is price, and cost is, you know, how much utilization is there and how much are we really spending for people in Canada, and it's quite high. There's the problem for prescribing practices. There's a concern that maybe we haven't quite got the health technology assessment formula quite right. There's certainly concern about limited drug budgets, both in the public sector and now more frequently even in the private sector than we've heard until now, that we aren't getting enough research and development from the pharmaceutical industry in return for their commitment to get some pricing protection and some patent protection, that we have an aging population, and that's adding to our burden, and that now we're getting much more innovation with rare disease medications and novel drug innovations, and all of these are creating a sustainability problem for the healthcare system. So on the next slide, I just, if we can move to it, you'll see that these right out of the report. So there were lots of broad areas of consensus, and frankly, I wouldn't disagree with any of them. We don't have people with coverage. They don't have enough coverage. We could do better with our money. We need some policy change. We don't want a poor system, but we need to do something about the cost. On the next slide, they go on to say that other issues are related to poor prescribing, the issue of prescribing practices, the issue of publicly funded prescriptions being evidence-based, and a number of these, the need for evaluation refinement. And on the last of the slides with the broad consensus statements, there is the, if we can just move to that one, there's the, Matt, would you, there we go. There's the goals being a program that would produce better health outcomes, but provide a good experience for patients. I'm not sure what that is. I think a good experience for patients is not to be a patient, but be that as it may. So it's hard to argue with these broad areas of consensus, and so, you know, if people just look at these and say, oh yeah, if that's what Pharmacare is going to do, we buy it, that's great. But when it really came down to what were concrete suggestions to bring this into to being. On the next slide, you'll see, and this is, I didn't see these words in the report. They're my words. Okay, we're a bit out of order here, but that's okay. The main solution that I heard in that room was a national list of drugs covered by all jurisdictions. That was the main sort of concrete solution to all the issues that were raised at that meeting. So what else has been going on in healthcare? After that meeting, I think it's important to note, well, before that meeting actually, it's important to note that the Federal Minister of Health mandate includes, from the Prime Minister, is to explore the need for a national formulary. So just to be clear, her mandate doesn't say look at Pharmacare. It says look at the need for a national formulary. And then there was a meeting of the federal, provincial, and territorial ministers in Vancouver last January, at which there was an announcement of a joint working group to study Pharmacare. And I think a big question is, what are they studying? We don't have any terms of reference yet. We don't even know who's on this working group. I'm not aware that it's met. And if it really is going to be what I heard in the meeting, which is a national list of drugs, and in line with the mandate of the minister, federal minister, which is a national formulary, that probably is going to be somewhat problematic. And I'm not sure that everybody would endorse that as the only solution to the gap for people to have access to drugs. So for those of you who followed the Liberal Party convention last weekend, they also endorsed the concept of Pharmacare. So it's definitely on people's minds. So so that's a bit of the history and a bit of very important, I think, for people to please remember that in terms of the solutions, we've yet to hear one that's more concrete than a formulary list. And so think about that as you hear the key takeaways. So we then had a panel of illustrious representatives from different stakeholder groups who have written about, been thinking about and writing about Pharmacare. And I'm going to turn it over to Martine Elias from Myeloma Canada to take us through some of the key takeaways from those panels.
Thank you, Louise, for that. Marc-André Gagnon, many of you may or may not know, but he is a health policy and public policy professor, researcher at the University of Carleton, and he's actually written quite a few papers, and he's part of I call it a gang of sort of key stakeholders in the health policy areas, of which Steve Morgan is one, Daniel Martin is another, Barbara Mintz, Jamie Daw, and Joel Lechin, who have written a paper called Pharmacare 2020. And it talks about the future drug coverage in Canada, and it really focuses on the national Pharmacare. And Louise made some comments about the roundtable discussion that happened last year in Ontario. And I believe Marc-André Gagnon was there, and the reason why he is quite important, what he has to say and his group has to say, is that they're very much listened by the governments, all the different governments provincially and federally. Actually, just at the end of, or middle of April, they did a Common Committee on Health in Ottawa about the future and the role of implementing a national Pharmacare in Canada. So these are people who are really important that stakeholders or governments are listening to, so it's really important for us to understand where they're coming from and what they are saying. So if you wanted to move to the next slide, please. One of the things that Marc-André presented yesterday is, you know, this is quite busy, but it really focuses on what their recommendation or their position is today with respect to national Pharmacare. So if you look at the middle, their vision is coordinated healthcare and pharmaceutical policies that promotes the health of Canadians equitably and sustainability, which makes sense, and everybody would agree that, you know, this is where we want to go. But if you look at what the objectives and how they want to prove this, That's where sometimes we do have some questions or some concerns about the direction that they're taking. So, when you look at, for example, the value on their objectives for prescribing drugs are comprehensive or competitively priced and represent value for money and used with Canada's universal health care. So that makes sense, but if you look at throughout their position, they really speak about value for money, cost containment, universal drug system, formulary lists. So those are things that are, sort of underpinning which we as patients should really take a closer look at, because what's important to us is really getting the right drug at the right time for the right patient. So, this is something you can take a look at, and you can find the information in the Pharmacare 2020. And if you just Google Pharmacare 2020, the future of drug coverage in Canada, you'll be able to find a link to it. So if you want to switch to the next slide, this is kind of the underpinning of where their position is coming from. So they're proposing a universal public evidence-based pan-Canadian comprehensive integrated pharmacare program with first dollar coverage for medically necessary cost-effective drugs, which really makes a lot of sense when you think about where we're coming from and why it's important to have a national formulary. But the question is how you implement this, and where do you want to go, and how do you take this to the next level. So if you want to go to the next slide, one of the things that I picked up from Marc-André's presentation is if you look at some of the principles that they've put on the table, they're really talking about, sort of the monetary or the value for money, and using health technology assessment to determine what that would look like. They're looking at bulk purchasing, so with the option of, or the benefits of containing at, some things that are good, eliminations of copay, deductible based on the official price, monitoring prescription habits and promoting rational use of medicine really all make sense. But what Marc-André was referring quite a bit is that, we cannot have an open bar for access to medication where everybody can go and pick whatever they want. So that's kind of what I thought from his presentations was alarming, and that we should really focus on changing the minds of people, that it's not about, having everything available, but having the right drug at the right time for the right patient. So if you want to move to the next slide, please. There was also a presentation on international comparison with other countries in the world, and both Marc-André and Neil Palmer from PBCI did a sort of review of some of the countries where they have a national pharmacare program, and in most of those countries these programs are part of their healthcare sort of the healthcare system or agency, so it's not a separate. So in Canada we have a national healthcare program, but drugs are not part of it. In those countries, if you can move to the next slide, picked up on some really interesting sort of facts, which I thought, and messages that I heard from the presentations. This one's from Marc-André Gagnon, where you look at Canada, so the total expenditure on a per capita base on pharmaceuticals, so this would be pharmaceuticals, prescription drugs, we're second in the world in terms of the highest per capita expenditure. And if you look at the middle and the green in the center, which is the OECD, where we're probably double of what they spend in the OECD. So his comment was that we spend a lot of money on medication for very little, well, for not as much value as we should be getting. We're going to move to the next slide. If you want to, okay, thank you. So, he also did the comparison with New Zealand, so he called them the Kiwis. So, in New Zealand, they don't really have access to a lot of drugs, and they look at health technology assessments and make recommendations, and drugs that are on the list will be reimbursed. When they get a no, it's a no. Again, They do tendering and they do reference pricing and they do PLA negotiations, and they also have some different clauses to reduce shortage of medication. But the net of what's happening in New Zealand is that a lot of people are actually moving to get treatment and to get access to medication to some of the other areas in the Asia Pacific because they don't have a list. They don't have drugs like we do in terms of number or access to the medicines because of the price and the pressures to control their cost. I want to move to the next slide. Both Neil and Marc-André, use the UK as an example of, where access to medication is under the National Pharmacare program or the Medicare program. And, we all know and heard about NICE and what they do in terms of the evaluation. NICE, does have what they call a negative list. So if you're not on the list, you cannot negotiate or be reimbursed. They have low or no, and they're divided under about 210 clinical commission groups. And each of these commission groups, think about them as provinces. And they each have their own budget that is set by the NIH. And I don't know how they manage it, but they seem to manage it quite well. And we've all heard of the innovative reimbursement scheme that the UK has put in place. One example is for Velcade with multiple myeloma, where if the drug doesn't work or the patient doesn't respond, the company will provide money back or to the government. So we'll replace the drug that's been used for that particular patient that was not working. So, these are schemes that other countries like the UK are looking at that may be something that could be evaluated in the national pharmacare system. Certainly something worth looking at. Recently, there was a report in the UK that looked at the performance of a number of drugs, especially in oncology, that were listed, and they were very poor in terms of the access to the new and innovative medicines. So the UK and the NIH developed the Cancer Drug Fund, which has just been launched in this spring in 2016. So hopefully we'll see some change in terms of access to oncology medicines in the UK. Germany and France are fairly similar in terms of their formularies or their Pharmacare. Their listing is based on price and it's negotiated with their different HTA or their agencies. In Germany, when an oncology drug comes to market, the manufacturer can, basically charge whatever they want for the drug for the first 12 months. The first 12 months. So during that year, the manufacturer must provide the information to the drug plan, and they will look at clinical benefits compared to existing drug. And if Germany says no, there's no benefit, then the drug is not reimbursed at all. And we've seen some pharmaceutical companies who have walked away, have taken their products off the market because the German authorities have not provided reimbursement for them. In France, they have quite a unique system. Price is allocated based on a clinical improvement scale, so they determine if your drug is breakthrough or has significant clinical benefit, then you can charge a higher price. But if you're the same or worse than another drug, then your price would be comparatively reduced. So it's quite unique in terms of the co-payments, and price negotiation will depend on the value of the drug. If you want to get to the next slide, please. I think that was, oh, yeah, sorry, this is my last slide where, I just wanted to reiterate the point that, I don't think we as patient organizations believe that a national pharmacare should provide an open bar and access to all drugs. Is from, and I thought he made the point so strongly that I thought it would be really, really important for us to understand, his perspective. And so I'm going to close here and pass it on to Antonella.
Thank you, Martine.
Actually, I
think Louise is going to go ahead.
Yes, if you don't mind, I'm just going to say a few words about about a model, because I was the third person on the panel with Neil, or I was actually on the panel with Glenn Doucette, who gave us the Pharmacists Association perspective. And basically, I don't want to speak for Glenn, but they're certainly open to looking at a number of models. I think one of the important messages that they delivered was also that pharmacy services should be included in the costs of these models, and that choice and access are very important. So, so he spoke. Then as Martine has mentioned, we heard from Marc-André Gagnon. We heard, and then I was the third person on the first panel because the Canadian Treatment Action Council, which I chaired for a number of years, actually wrote a paper in 2009 called Nobody Left Behind, which probably wasn't a good title, but we didn't know it at the time. And I'll just give you a bit of an overview. We proposed not Pharmacare, but something called Universal Catastrophic Drug Plan. And the catastrophe is not related to, it's kind of, it's related to two things, the severity of the illness, but also to the cost being catastrophic for the person. So just to support Martine's comments, you'll notice that we did not suggest that cosmetic treatments should be included in any plan paid for by the public system. That should be discretionary for somebody who wants to pay the money. It's about drugs that are medically necessary and prescribed by regulated healthcare professionals. And what we proposed at that time was a legislated addition to existing public plans, and now I would say and private plans, since they're starting to become a big part of the scene in terms of exclusion and access, where they didn't seem to be much of a problem in the past. So the idea is that it would be multi-stakeholder funded. There would be some government funding, there would be business funding, industry funding, and certainly citizens, residents in Canada who had access to the plan would also pay through a system based on their taxes. And it would include rare diseases, and it would be universal, and it would include drugs, biologics, anything that's approved by Health Canada and medically necessary. So if you think about, if we could turn to the next slide, we'll show you a little bit more about that particular model. And so the idea is that it would be first dollar coverage, that it would be a sliding scale, cost sharing based on family income, but as I've mentioned, federal governments and employers would also contribute. It would be $0 for people in the lowest tax bracket, and we would have to really work on what the percentages ought to be in the higher tax brackets, because going back to the very first slide about the National Pharmaceutical Strategy, you'll recall that the issue they were trying to deal with, and it's the one that we still think is the most egregious, is that there are some people in this country who have no coverage for their drugs at all, or are profoundly underinsured. And they're our first priority in terms of help. So if I would think of this, if I would think of our proposal at that time, sort of graphically, if each of the provinces and the federal government plans are silos, then whatever those governments could afford, and I would put the private sector now as a silo as well, whatever they could afford based on their healthcare budgets, they would pay as they do now. But then there would be like a safety net underneath all of those silos, and it would pick up the people who still had medically necessary drugs, which had been prescribed by their doctors, but were not covered by one of those either public or private plans. And it would save them. It would be their safety net. And that's kind of that was what we were thinking about at the time. And I must say, honestly, my thinking hasn't changed a whole lot about that since that time. I still think that that would be something that we as an organization would probably support. So now I will turn it over to Antonella, and as I mentioned, Antonella Scali is a member of the Schizophrenia Society of Ontario. A wonderful, the mental health community has become a wonderful partner with oncology. We're very glad to have them as partners. And of course, I think all of us with serious physical illnesses recognize that these illnesses are inextricably linked with, in some cases, very serious and legitimately serious mental health issues. So I think this was a lens that we felt very strongly ought to be considered in any vision and values that we held as oncology groups. So at the next slide, could we have the next slide, Matt? There we go.
Thank you. Thanks, Matt. Thanks, Louise. So as Louise mentioned, my name is Antonella, and I'm with the Schizophrenia Society of Ontario. And just to provide some context, we're a province-wide nonprofit mental health organization that provides support, education, research, and advocacy for individuals, families, and communities affected by schizophrenia and psychosis. So as Louise mentioned, we did attend yesterday's roundtable because there is a significant overlap between the different health conditions, but also between our concerns with Pharmacare and those of the oncology groups that were present. So SSO has access to a wide range of treatments and supports has been a long-standing policy priority for the SSO. So this means, social supports such as housing, employment, family and friends, as well as community services like counseling and peer support, and psychiatric treatments like hospital-based care, psychiatrists, and medications. Specifically, we've been looking at the medications piece because Ontario's 10-year mental health and addiction strategy, which was first launched in 2011, has entered into its second phase. And although the strategy strives to be holistic in its approach, notably missing from its perspective currently is this whole access to medications piece. And this is really problematic because, as you know, medications are often used as a frontline treatment for mental illnesses, and because all treatments and supports work together to enable individuals to meet their unique mental health and recovery goals. So Matt, if you want to go to the next slide, please. I'm just going to talk a little bit about the context in which we became involved in this conversation and an ally to the oncology patient advocacy groups. As Louise mentioned, there is an undeniable intersection between mental health and physical health, and specifically oncology. We know from research that diagnosis and treatment of cancer have a significant impact on mental health, and there is current research that shows as well that people with schizophrenia, for instance, who are diagnosed with cancer, have poorer health outcomes than the general population. There are various different reasons around this. For instance, certain individual behavioral things like increased or higher risk of smoking or medication side effects may impact on physical health, as well as stigma within the health field that may impact a person's ability to seek out treatment when they do have that need. And so what we find is that people with mental illnesses are often using more than one medication due to the presence of other concurrent physical and mental health conditions. So when we talk about and advocate for better access to medications for our constituents, we know that this goes beyond antipsychotic medications, beyond psychiatric medications, and our concern is about the system as a whole. So Matt, if you can please go to the next slide. So what we found as well is that as well as having kind of dependencies across the two health conditions, there's also intersection between the issues to accessing medications that we have in common with the oncology patient advocacy groups. And these include things like difficulties with accessing needed medications because of affordability. So many people are uninsured, can't afford to pay out of pocket for prescriptions. Others who experience low income have trouble paying deductibles or co-payment fees. Gaps in transition between plans and systems is a big problem we find with our constituents as far as within the current patchwork of private and public programs, individuals often have to move between these different forms of coverage. And since availability of medications, eligibility criteria, and administration processes vary across these programs, people often fall through the proverbial crack during these transitions. And that can be very disruptive to achieving mental health goals and recovery. And then delays in medication listing timelines, so backlogs in applications and redundancies in medication reviews and health technology assessment processes delay access to new treatment options. And what we also found is that listing decisions and system sustainability. So funding and listing decisions and priorities are often influenced by, immediate financial economic considerations rather than secondary costs associated with untreated mental illness and its impact on individual and family quality of life. So part of what we're looking at is how do we ensure that who's defining value when it comes to deciding who's the listings for formularies. So as we've mentioned at the beginning, this all goes to say that, again, Pharmacare is defined by a common national list of drugs covered by all jurisdictions, does not solve these issues, and in fact, would perpetuate the issues that we find to affect the people and families that we work for. So just the next slide, please, Matt. So just to highlight some key considerations, Louise will elaborate on the key takeaways from the roundtable yesterday and the draft vision and values and principles. I just want to highlight from a mental health perspective where there's some key overlap in some of the conversation that came up. So as an organization and based on the discussions at the roundtable, we found that it's important in this dialogue and vision for Pharmacare that it's contextualized within a broader vision for Canada, which sees that all people residing in Canada have access to therapies regardless of social determinants of health. And we know, for instance, with people who have schizophrenia, there's increased difficulty accessing healthcare services, employment, housing, social services, a lot because of the stigma directed toward mental illness. So we really have to make sure that conversation is happening within that context. And additional values and principles that came up, and again, that will be elaborated on, are upholding equal opportunity to the structural social determinants of health, protecting existing individual access to therapies at their current level so that nobody's losing access or their current access is being undermined by any new Pharmacare program that's being put into place, and ensuring access regardless of ability to pay. So this is crucial because, again, all aspects of health and well-being work together to support people in recovery. So we want to make sure that a system addresses the affordability issues. We also highlight that retaining pharmaceutical system savings within the Pharmacare budget is important in order to ensure a sustainable system. And lastly, just ensuring recognition and value of real-world evidence in determining therapeutic value, because we know that the people that know best about their own definition of recovering quality of life are the people who are experiencing it. So we want to make sure that that input is included. So that's a kind of general overview from the mental health perspective, and we look forward to future opportunities to work as allies as we examine the models that are put forward for Pharmacare. So thank you, Matt. You can go on to the next slide.
Thanks so much, Antonella. One of the other presentation we had, in addition to looking at some models and looking at some of the international issues and purported best practices, was we listened to some health economic advice from health economists, and I would say that as complicated as it all was, the bottom line was that there had actually not been, at least according to the economists who were in the room yesterday, a detailed economic analysis and forecasting of the cost of a universal drug plan, that it's actually never been thoroughly undertaken. So I thought that was worth noting, because there are many of the models that are proposed have dollars attached in terms of either savings or costs or neutrality of cost, and yet the health economists tell us that really the modeling that we would need to do has never been thoroughly been undertaken by the economists. So I guess we don't know. I guess that's the bottom line. So now, if we could turn to the next slide, I'd be pleased to unveil for you. This is some of the international comparators. I won't spend much time on this, because Martine has covered a lot of it, but I do think that the bottom line that we took away from the international comparators, we often hear about other OECD countries having a universal drug system, that we're the only ones who don't have a universal drug system. However, it depends on how you define universal. So what we learned yesterday is, yes, there are many countries, and Martine has pointed out some of them in detail for you a little earlier, that they are universal in the sense that the entire population is treated in the same way or included, but inclusion does not mean for all treatments, and we were not shown any plans that did not have some cost to the participants. So this is something that I think we need. Depends on how you define universal. So having said all of that, we gathered up, and in the next slide, we'll start to unfold our vision. You're the first to see it. So what we did after listening to all of this really wonderful information was to say, we're not going to jump into the pool and try to develop another model. All of these models are very interesting and certainly have pros and cons, as the Pharmacists Association presented in their presentation, the pros and cons to all of these. But what we decided to do instead, the oncology and mental health groups who were there, was to say, number one, what is our vision of the best world we could live in? Now remember, this is aspirational. And then, what are the values and principles by which we would look at any proposals made to us by governments or other stakeholders for a particular Pharmacare plan, program, project, whatever wording they use. So the world we in that room yesterday want to live in is a world where all people residing in Canada have timely, inconsistent, equal, and equitable access to safe, appropriate, and effective therapies, including treatments and medications, as well as the information, diagnostics, care, and support that they need without conditions. And that is intended to cover the concept of where you live, how much money you have, unconditional. And with that, the best possible world would be a broader vision that every person would have equal access to therapies regardless of social determinants of health. And we know that Health Canada has developed a long list and one that we endorse very strongly, of what are the social determinants that directly impact people's health. And we do not want any of those to be barriers. In the world we live in, none of those would be barriers to good health. So that's our vision of the world, and that's the lens through which we would look at anything that was brought to us. Does anything, any new public policy in health or anywhere else, bring us closer to this ideal world than we are now? If it doesn't, we're probably not interested in it. One of the other things I would just make a comment about that came out in in Don Husserl's presentation, the health economist that we spoke to, or who spoke to us yesterday, one of them, is, he reminded us that every time you change a system, there is a huge cost to changing that system. So, we do want an ideal world, but we don't want to make changes to systems that we don't need to get closer to that ideal world just for the sake of making a change, because there's a profound management cost, as he called it, change management cost that goes with changing any kind of systems that we have. So how about our values? So let's move to the values next. And here are the values and principles that we think need to be part of any Pharmacare proposal. One is respect for people who access the health system and their support team. Two, meaningful and ethical engagement of people who access the health team, including engagement in health systems planning, decision-making, implementation, knowledge, transfer and exchange, monitoring and evaluation, and systems redesign. We would want to ensure that universality and equality, recognizing diversity and accommodation is a principle of any Pharmacare system. Transparency and information sharing in all health systems processes and health policy decisions would be mandatory as a value. And we have a few others on the next slide that we also would include. If we could go to that slide. So we believe that there needs to be support for health innovations in any Pharmacare system that is presented, including access to innovative therapies as required. Now, that is not to say that we do not respect and value generic therapies, subsequent entry biologic therapies where appropriate. Everything is on the table, but certainly there are cases where innovation really is the only answer and is the best answer, and we want to ensure that that's retained. We also really believe in excellence in health systems and health policy, including the recognition of the importance of integrating best practices in evidence-based qualitative and quantitative medicine, and the importance of an accountability framework for all health systems, processes, and health policy, not just within the drug system, but across the whole healthcare system. And we certainly believe in the value of capacity building, the principle of capacity building and mentoring, as well as social justice to uphold equal opportunity for all social determinants of health. In addition, on the next slide, we went on to talk about some other principles that we believe in, which include ensuring the protection of existing therapies at their current level. So, in other words, making everybody the same, where the implication of that is that some people will get less than they get now in a Pharmacare system, would not be acceptable to us. We are very happy to have people move up and get more than they have in the past. In fact, we know that we need to do that. But if the implication of getting equality or equity is a downward movement for any individual to what they're presently able to access, that would not be acceptable to us. We also want to ensure that there is access to medically necessary therapies for uninsured and underinsured residents of Canada, regardless of ability to pay or place of residency. So if any Pharmacare proposal is put forward that will not do that, then we would not be supportive. We also want recognition of the discrete and distinct needs of people with life-threatening and serious debilitating illnesses that significantly affect their quality of life. There just is a profound difference between those types of illnesses and other illnesses. Not that all illness is bad, it is, and not that they all shouldn't be treated with medically necessary treatments. They should, but the way and the processes that we look at are somewhat different for both, and we would want a Pharmacare program to recognize that. So we have a few others on the next slide that are also values and principles for us. We want recognition and value of determining therapeutic value, and we want to ensure that pharmaceutical system savings are retained within the Pharmacare budget in order to provide increased access to therapy. We would want Pharmacare that builds on healthcare mechanisms and systems already in place. As I mentioned, our health economist was clear with us that the more you change a system, the more it's going to cost, and of course the longer it will take for that system's change to occur. So we don't want to change things. If the house does not need to be rebuilt, if all we need is to paint some rooms or put in some new windows, let's do that. Let's not rebuild just for the sake of rebuilding. We also feel very strongly that the development of value-based drug pricing contracts, including systems for data sharing and other relevant information, must be developed, because no Pharmacare system can really be effective if we don't think about the pricing of drugs. So to the next slide, if we could. We also feel strongly that we need to analyze the value of a drug for a Pharmacare system that includes savings in other parts of the healthcare budget, and also looks at broader socioeconomic impact, like ability to return to work, cost to caregivers, things that are generally not accepted in the present system. And we would like to expand the health technology assessment processes, good health technology assessment processes, to measure the value of all components of the healthcare budget in the same way that we have now. If we could move to the next slide, I'll be glad to show you some of our next coming out of the meeting. We agreed that we will finalize the report, which will include these vision and values, which we will disseminate broadly for endorsement among patient organizations. We will then disseminate the final report with the signatories to all stakeholders, including government, policymakers, healthcare professionals, academics, and anybody else who's interested in like to write to the Ministers of Health and ask for inclusion of the agenda item of Pharmacare on their forthcoming meeting in the fall, and an opportunity to speak to that issue. And of course, we will continue to seek all opportunities for public education through media and any other sources that we can find. So that's where we ended up at the day. I should have mentioned at the outset that if you have questions, yes, the last slide is just what you can do to help. Certainly, if you're a patient organization or an individual who would like to endorse the finalized vision, values, and principles, delighted to have you do so. We'd appreciate you disseminating holders that you know, including members of your organization. Appreciate you considering meeting with provincial and federal representatives to talk to them about what you think about Pharmacare and what your vision and values are. And certainly if you would like to join us in continuing to work on this project, which we will certainly be doing, please get in touch with Jackie Mann, President, and we will be pleased to find some good work for you to do to move this agenda forward. So I'm not sure if there are questions. Matt, would you, if there are some questions, maybe you could read them out?
Absolutely, Louise, I can do that for you.
Thank you.
We have one. It's a mouthful from Stacy here, so bear with me and I'll get through it. Okay, she said, did you have any ideas of how to measure or how to monitor that the savings in Pharmacare are in fact invested back into the Pharmacare budget? The savings in Ontario have always been hard to measure and qualify that they went back into innovation and not general revenue. Any thoughts on what you would want government to do in this regard?
Well, I'm not an accountant, and so I wouldn't pretend to know. We didn't talk about this. We didn't get to that granularity certainly yesterday, but we would definitely want. We would like to see public. If there is some form of Pharmacare system put in place, we would want public reporting and monitoring and evaluation of that system, and we would want that report to be tabled with government, and we would want certainly part of that to include budgetary description, including how those savings have been retained, how much they were, how they were retained in the system, and how they were used in the system. And that's about as specific as I can get at this point, because truthfully, we would have to work with people who know much more about how to do that. But in principle, that would be very important to us.
Louise, it's Martine here. If I may add, I heard the sentiment from the presenters, from our stakeholders that joined us yesterday, that yes, this would be something that would be definitely worth measuring. And ensuring that, you know, if we're saving money in Pharmacare, that money goes back to offer more drugs for more patients that would need it. So, and to Louise's point, how you do it, the granularity, it's, you know, still a huge question to address and answer.
So I'm not sure if there are any questions. Any other? I'm not aware of any other questions. Are there any other questions?
Not as of right now. Stacy just said thank you for answering her question, so no problem, Stacy. But yeah, as of right now, there's nothing. There's nothing else that has come in yet. We still have 5 minutes left, so I don't know if there's anything else you want to get in before we finish up here, Louise, or anybody else, Antonella or Martine. But I'll let you guys know if there are any questions in the next couple minutes.
Well, yes, just to say, oh, here's, I think we just got one in. Detailed reports are available. How can we access those reports? Sharon, I'm not sure which reports. If it's the reports that each of the presenters put in, I'm guessing maybe it's the actual proposals that they have made about Pharmacare. Those are definitely all available, and we would be pleased to send out a copy of each of the pre-reads that we got, which were copies of all the different proposals that each of the presenters has made. So if that's what you're looking for, we can certainly provide that. If it's something else, you'll have to help me out with which other reports you might be referring to. That was it? Oh, excellent. Okay, good. Yes, just write into us, and we'll be pleased to share those reports with you. Okay.
I think there's another question.
Oh, yes. All right. You mentioned that Pharmacare would be equal across Canada. Would that be each province too? Yes. It would be equal in the sense that we understand that provincial budgets will never be the same in healthcare. They will not be equal in every province. Each province has its own sort of economic realities, its fiscal opportunities, and so I don't think it's realistic to expect that a provincial budget on its own could ever do that. But the concept here would be that there would be some form of shared funding that would fill in the gaps that happen as a result of the fact that they're not the same across the provinces, and would pick up medically necessary treatments for people in provinces where what they need cannot be accommodated through either their public plan or a private plan. So yes, that would be the intention, is to smooth out the bumps across the provinces. Oh yes, Maureen. So I hope that answers your question. Maureen is mentioning, yes, that in addition to the other things that are going on at the moment, the federal government has set up a set of hearings under its HESA committee, and they are hearing testimony. We hope that we are certainly going to send them a copy of our vision and values, and we certainly hope that they will give us the opportunity to present. I know some of you on the call have had an opportunity to present, and I know that those committee discussions are still going on. So we're hopeful that we will also have an opportunity to testify before that federal committee. Thanks, Maureen. Any others? Well, we're just at the, I think we're just at the 2 o'clock. Oh, wait a minute, there is one more. In the models that were proposed, was there consideration of equal access to drugs covered by hospitals? Specifically, access to IV cancer drugs is not the same. We didn't speak, specifically about hospitals, but our principles would certainly include the principle that wherever your drug is being administered should make no difference, whether it's being administered in your home or in a hospital. You should have access if it is a medically required drug, and whether that happens through hospital budgets, whether it happens through provincial formularies, private plans, or at the end of the day, if none of those will do it, then that's where our Pharmacare proposal would come in and pick up these medically necessary costs. So we didn't speak specifically about that, but our principles would definitely ensure that they would also be covered.
Okay, so it looks like we're just at the end of our time here. So if there are any more questions that people have, feel free to contact either Jackie or Louise or anybody on the call. I'm sure they'd be happy to answer your questions. But for now, I think I'll just say that I want to thank on behalf of CCSN, Louise, Antonella, and Martine for coming on today and relaying all this great information for us from what came out of the meeting yesterday. And like I said before, if anyone wasn't on the call at the time, there will be a full video on YouTube tomorrow, as well as the slides, which will be on our SlideShare account. You'll get links to both of those things tomorrow, and they'll come up to your email tomorrow afternoon. Other than that, I hope everybody has a wonderful day, and we will see you on the next webinar.
See you later. Bye-bye.
Thank you.
Thank you for listening.